come in. Oh, no worries. All right, well, I apologize. I was waiting to hear some chimes out in the hallway there, but I'm moderating this session, so I'm going to ask everybody to come back in and take your seats. I just have to read these notes. All right, so we're going to be starting the next abstract session, which, am I able to pull them up somehow? Do I have the, I'm going to pull up the title? Oh, there it is. Okay, excellent. So just as a reminder, please share your comments and questions with the speakers. There's also still time to sign up for the hands-on ultrasound guided block workshop, which will be taking place later. Please join us in the reception hall and the exhibit hall a little bit later, and feel free to mingle with our industry sponsors. Our first talk today is entitled Postoperative Urinary Retention After Elective Spine Surgery, a systematic review and meta-analysis by Dr. Yang from the University of Miami.
Thank you very much. My name is Michael Yang. I'm a clinical spine fellow at the University of Miami in the Department of Neurological Surgery. Much of the work I'm presenting today was actually conducted out of the University of Calgary in the Department of Clinical Neuroscience when I was a resident. So I have no conflict of interest, but I did receive research funding for some of the work presented today. So the definition for postoperative urinary retention after spine surgery is really varied in the literature, but it's typically defined as the inability to void after a spinal operation. Postoperative urinary retention, or POUR, leads to poor outcomes, such as increased length of hospital stay for the patient, increased healthcare costs for the hospital, increased risk of urinary tract infections, as well as postoperative discomfort and pain. Even though it is relatively a common complication after spinal surgery, the true incidence of POUR after spinal surgery is really unknown, and the risk factor is not well elucidated. So the research objective of my project today is to determine the incidence of postoperative urinary retention after spinal surgery, and secondly, to elucidate the risk factors for postoperative urinary retention. And we did this via a systematic review and meta-analysis, searching the Medline, Embase, CINAHL, Cochrane Library, as well as Google Scholar for electronic database search. So this is the PRISMA flow diagram. We looked through about 1,500 titles and abstracts, and eventually we included 34 studies into the quantitative analysis and meta-analysis. So in terms of study characteristics, we included 34 studies. The sample size of these studies ranged from 95 patients to 25,000 patients, with a total sample size included around 40,969 patients. In terms of the location for surgeries, the vast majority were cervical and thoracolumbar. Approximately 50% of the included studies were those type. 30% thoracolumbar only, 21% cervical. The vast majority, in terms of the pathology, were degenerative conditions. Few of them were cancer, but mostly degenerative. The definition used for postoperative urinary retention is really varied, and there really is no consensus in our findings. Some studies use qualitative definitions, as simple as just the inability to void that the patient reported, up to discomfort or pain to suprapubic palpation. In terms of quantitative analysis, it's also very varied. Some studies use greater than 100 cc's in post-void residual. Others are greater than 500 cc's. And other studies also included just 3 or more intermittent catheterization as their definition for POUR after spine surgery. So in our meta-analysis of 40,000 patients, we found that the overall incidence of POUR was 8.8%, with a confidence interval between 8.1 and 9.1%. These are the risk factors for POUR. We found 10 risk factors to develop POUR after spinal surgery and 2 protective factors. So under the demographic parts, older age and male sex, no surprising, are risk factors for developing postoperative urinary retention after spinal surgery. In terms of comorbidities, history of BPH, history of diabetes, as well as a BMI of greater than 30 were risk factors, as well as history of urinary retention. History of urinary retention after previous surgery is probably the most important risk factor, with an odds ratio of about 15. In terms of surgical factors, duration of surgery, so longer the operation, the more likely to develop POUR, fusion surgery, as well as the use of BMP. Many of these studies were not did not include a multivariable model, so the use of BMP and fusion may be covariates that would be canceled out if it was a larger prospective study. In terms of perioperative factors, we found increased intraoperative IV use was associated with POUR, but the 2 protective factors were ambulation on the day of surgery with the odds ratio of 0.54, so decreased the odds by almost 50%, and as well as the implementation of an ERAS program in that institution were also associated with a decreased risk of postoperative urinary retention. In conclusion, the incidence of POR was 8.8% after spinal surgery. We found 12 risk factors, and these are potentially important risk factors when counseling patients preoperatively on their expected chance of developing POR and discharge planning purposes. In terms of modifiable risk factors that was identified, we found ambulation on day of surgery, the use of BMP, intraoperative fluid use, as well as ERAS program for spinal surgery to be potentially modifiable. Thank you.
We'll take all the questions at the end. Our next speaker is from Atrium. Dr. Ivan's going to be chatting about which modalities matter, compliance with non-narcotic multimodal analgesia and association with MMEs in a cystectomy ERAS pathway. Dr. Ivan.
Thank you. My name is Sam Ivan. I'm a third-year resident in urology from CMC in Charlotte, North Carolina. Again, today I want to focus on identifying which modalities are important in non-narcotic multimodal analgesia, specifically to us in a cystectomy ERAS pathway, but I think a lot of this will align with what we've talked about earlier this morning as well. So our protocol, it was initiated in January of 2017. The cohort we're discussing today consists of 207 patients. And in this cohort, we have previously demonstrated decrease in narcotic utilization. I think that's an outcome that's been common in ERAS protocols and findings and is often attributed largely to the use of non-narcotic multimodal analgesia. Again, that's one of those tenets of ERAS protocols that's sort of been steady throughout. What our interest has really been is to dive deep and try to pinpoint what types of medications or what things are actually driving those outcomes, and if there are any that may be redundant or unnecessary. So this is a snapshot look at our multimodal analgesia protocol. You can see in each perioperative phase there are targeted medications designed to provide non-narcotic analgesia. Our focus today is really in the postoperative phase, as some of those medications, specifically the Toradol and the gabapentin, we suspect are not utilized as prescribed. So our goals here: describe the multimodal analgesia compliance and identify reasons for non-compliance within our pathway, and then explore any effect that those medications may have on inpatient MME morphine milligram equivalent scores, which we're using as an objective measure of narcotic utilization. So here is what we did to break out those compliance metrics. In general, looking at the Toradol and the gabapentin, compared to Tylenol, which, as you can imagine, most patients receive, for Toradol, those who received it as prescribed was really only 35 to 45% of patients, and for gabapentin, the number was about 40 to 50%. So there's a lot of variability that we identified. So we created these compliance cohorts looking at those who got both medications, neither, or one or the other, just to see where things shook out. And you can see here already, more patients received neither of the medications than received both. And one other thing to note here, on post-op day 3, the Toradol drops off just because at that point in our protocol it becomes an as-needed medication, so it's a little bit more harder to quantify. We then did a multivariable model to control for tap block and specific surgeon, looking at any effect of these medications and those compliance cohorts on that inpatient narcotic score. As you can see, in our cohort, we didn't identify any difference between the use of Toradol, gabapentin, one, the other, both, and the use of the narcotics. Interestingly, in separate analysis, for those patients that did receive tap block, there was a statistically significant decrease in narcotic utilization on post-op day 0 and 1, and during that time period in our cohort, we saw about a halving of the narcotic utilization in our patients. Looking then deeper to try to figure out what's the reason for the variability in the usage of these medications, this is looking at a manual review of provider documentation, trying to identify the reasons for dose decrease or discontinuation of medicines, and this is summed from post-op day 1 to 3 for both of these medications. You can see the most common reason is a concern for renal function, which isn't surprising in a cystectomy cohort where patients are already advanced in age. But I think what is more interesting is looking then at the second most common cause, that kind of dark green space, which we labeled provider preference. And to us that just meant that there was no medical indication, no documentation that would explain the reason for removing or decreasing that medication. And to us, that indicated some concern or hesitancy on the part of our providers for utilizing the medications. And to us, that triggers that this is increasing the decision-making complexity in our protocol. And so really, in conclusion, one, we identified that the compliance with the Toradol and gabapentin components was quite variable, not what we expect. The reasons being renal function, a provider preference or concern with the medications. Two, we didn't identify any association in this cohort between Toradol and gabapentin use and their narcotic use inpatient. And I think the big takeaways then are one, which I think we've heard before, just the importance of having an auditing system in place to review and follow ERAS protocol outcomes, because I think this demonstrates the difference of those medications that you expect to be used in that multiple analgesia pathway, but are not being used as you expect. So I think that's the biggest takeaway, is just knowing what is happening and being able to then respond with those changes. So what we'll be doing in the future is removing those medications from our protocol and then reassessing these pain outcomes to see if there are any differences. So happy to take any questions at the end of this session, and then again, here's my email if you'd like to direct any questions that way. Thank you.
All right, thank you very much. And our last speaker for this first set of abstracts will be Dr. Bushnell, who's going to be telling us about perioperative acute pain management.
Thank you, everybody. Thank you, Kevin. This is me. I placed myself in my work clothes because of my clinical anesthesiologist with the Shriner system. I spent about a third of the time in the operating room, a third of the time in clinic, where we see 100% of patients a week and a half or a week pre-op, and then we see 100% of our patients a week or a week and a half post-op in ambulatory clinic. I would argue that this is the only place in the world where we get complete capture by an MD anesthesiologist. It places us in the position to know our patients really well, our pain protocols really well, to come up with some novel ideas. I'd like to shift the thinking maybe to preventing pain, not just preemptive, but preventing pain. This is quickly the Shriner system. This is the third hat that I wear. I'm the chair of the Anesthesia Executive Committee, and I write policy and protocol and administer procedures for 22 hospitals in the United States, Canada, Mexico. This is what the Shriner system does for young children. We take kids in, we treat them for free, sometimes we treat them for life, and we expose them to this prior to 2013. This was our primary, OxyContin was our primary pain management system. Now, I'd like to linger for a second here. First order pharmacokinetics is all I'd like you to remember out of this lecture. Okay, notice that this is the first thing you all forgot in nursing school, medical school. This is the first graph we all forgot, that it takes 5 half-lives to reach maximal sustained blood levels. This is why you heard me harp all the way through. When did you give your pre-op loading? Okay, why are we doing this? The standard pre-op loading the day of surgery. Okay, why? First order pharmacokinetic loading. We dose 48 hours before surgery, 3 meds. Okay, we've all got 3 meds, acetaminophen, Celebrex, gabapentin. Why are we not using the 2 days before? Okay, these 3 meds are magic if you use them properly. We dose them in kids according to a weight-based protocol that we've worked out at every 5-kilogram patient. We also provide post-op coverage in case these 3 don't work. Okay? Notice that we're dosing 2 days before A, C, and G, acetaminophen. This is the instruction sheet the patients get. This is the patient-reported outcomes. We keep track of every opioid dose. This is our result years ago. It was so effective we couldn't withdraw it to do a study. I wrote the protocol and initiated it, and it was so effective the surgeons turned their years of pain writing pain management programs over to me. Okay, pros. It's cheap. We got generic medications. You can go for immediate implementation. We use fewer opioids. Cons, it's more work for you. It's more work because you have to spend more time with your patients. We are the barrier to entry. Patients will get up at midnight, take it. They'll get up at 6 in the morning, take it. They'll take it at noon. They'll take it at 6 at night. They'll get their kids to take all these pills. But we are the barriers to entry. They will go for non-opioid anesthesia, analgesia. Pain is the most common denominator between all of these surgeries. Opioids are the central evil to our ARIS protocols. Okay? Just remember that slide there on the left. First order pharmacokinetics have a rational basis, if you will, for when you're going to dose. Like I said, the one dose of acetaminophen, what does that do? And then this is my inspiration. Win first, then go to war. Every battle is fought before it's won. Won before it's fought, excuse me. Every battle is won before it's fought. 4, 3, 2, 1. Thank you.
We turn on the mics at the, here, yeah. All right, we'll now take some questions for the speakers here. Dionysus?
Dionysius Rohidis from Charlotte, Atrium Health. Dr. Bushnell, first of all, let me start by saying that I'm humbled by the type of work you do. And to me, this is something that very, very few of us can do. I would like to ask you the following. I understand that there is no reason to perform a randomized trial so as to prove something that you have already feel and you see in your daily practice that it's very, very beneficial. However, do you have any retrospective data, especially stratified by patients that they completely follow the protocol and by patients that they didn't follow the protocol? Because it would be very beneficial for the rest of us to understand exactly, especially by type of surgery, what is the amount of benefit that we get by preventive analgesia.
That's a great idea. It is exceptionally hard to do research in the Shrine. It's exceptionally hard to do a randomized controlled clinical trial in pediatrics with 4 medications. I have not done that, and that's the caveat that I have to put forth here. What data does it take? I don't know, but I haven't done a large-scale clinical trial. I'd be perfectly happy to participate in one.
Because I would say that the greatest barrier is indeed us, but also absence of data. We need to have that.
Yep, I agree.
Thank you. Thank you again.
Wish I had some.
Yeah, I can tell you anecdotally, because Rick's been talking about this for a couple of years, I have done this on occasion for chronic pain patients with good results, for what it's worth. And I have somebody who I'm expecting is not going to do as well in the ARIS protocol. I will prescribe them preemptive medication a couple days ahead of time. So, any other questions? All right, I have a couple questions for our speakers. For Dr. Yang, in the POUR study, are you able to control for Flomax use, or do you use Flomax routinely in spine patients to try to reduce urinary retention?
We don't use Flomax prophylactically unless they do develop, but even the evidence for that is quite iffy. Because this is a systematic review of meta-analysis, we only analyzed potential variables if they were presented in 2 or more studies that we can do some sort of analysis. It's interesting that there's not that many studies that looked at Flomax and whether it's efficacious after spinal surgery. So something to look into because we use it all the time.
Any thoughts from our urology colleague on that? So.
Yeah, I think we sort of wanted to throw the kitchen sink at people type of things. But I don't know that in the short term somebody comes out of surgery and is already in a urinary retentive state that you can count on that to change things.
By the way, I was quite surprised there was an RCT that came out recently in female patients for using Flomax urinary retention, showing that Flomax actually works in women as well as men, which is contrary to what I had often learned for many years as a gynecologist. So. And then, Dr. Ivan, for your presentation, so you found that it didn't matter if patients were compliant with the protocol or not. Their pain outcomes seemed to be similar. Do you attribute that to the fact that the rest of the protocol is sort of buttressing them? I mean, it's sort of like saying I can fly a plane with 3 engines instead of 4, but should I fly with 3 engines instead?
Yeah, I think that was the idea that we were sort of getting at, is we know that, and again, it's sort of a surrogate marker, but the decrease in narcotic utilization is something that has been a boon to ERAS and has outcomes physiologically throughout the whole protocol. And so what's driving that? And so I think this hints to us that it may not be some of the non-narcotic multimodal analgesia elements that we think it may be. And then specifically, stepping back for a cystectomy protocol where patients are in their 60s and 70s, you're messing with the urinary tract, you got a big fluid shift for a big surgery. Already then medications like ketorolac and gabapentin may not be the best choice. One of the data points we came up with was, if you look at those compliance measures, at least 50% of the time, each day, a provider, a resident, or an APP is going in and manually adjusting that medication. So that adds a significant amount of complexity to your ERAS protocol that I think you have to account for. And so if you can get the same narcotic effect or pain effect without them, with a tap block and with preoperative medications, things like that, maybe less is more.
Very provocative. Okay, thank you very much, all three of you. Excellent. Do we have the speakers for the next round of abstracts? Come on up. I don't have the list in front of me, but if we can bring up the first abstract. Excellent. Oh, I'm sorry. So first, all right, first we'll be hearing from David Levy from the University of Miami, telling us about thoracolumbar interfascial plane blocks for versus traditional field blocks. So, Dr. Levy, please go ahead.
Hi, my name is David Levy, and I work with Michael Wang, our senior author, and Damien Brusco and Victor Liu, our co-authors for the University of Miami, to do a thoracolumbar interfascial plane block and see how it reduces opioid consumption in the acute postoperative period compared to the traditional field block. Using a non-narcotic method of pain control is superior to using narcotics, and we thought using an infiltrative local anesthetics intraoperatively could accomplish this. Reducing postoperative opioid consumption helps reduce the risk of complications such as ileus, urinary retention, as Michael Yang talked about just a couple presentations ago, and nausea and vomiting, and this can help reduce patients' time in the hospital. So the goal of our research was to compare postoperative narcotics consumption following injection of liposomal bupivacaine, and compare that between transcolumbar interfascial plane blocks and a traditional field block. Our study was a retrospective review of a single surgeon series of 136 patients. The most common lumbar fusions that we did were a laminectomy infusion and a transforaminal lumbar interbody fusion. And the patients were divided into a TLIP or a traditional group based on the infiltrative method that we used to apply the anesthetic. Analysis were conducted using a chi-square exact test for categorical data and Wilcoxon rank sum test for continuous data. And the alpha level we used to determine statistical significance was 0.05. Application of a TLIP block. You can't see my mouse. Okay. You use a 22 gauge spinal needle with ultrasound guidance to find the interface between the facet capsule and the transverse process. And then you inject the local anesthetic into the multifidus and longissimus muscle to block the dorsal lumbar rami. The anesthetic we used was a mixture of 20 milliliters of liposomal 1.3% bupivacaine and 40 milliliters of 0.25% bupivacaine hydrochloride. After the initial injection, as you're removing the needle, you inject the remaining anesthetic into the surrounding tissue. For the traditional block, there's two different methodologies depending if you're doing a minimally invasive surgical case or an open case. For minimally invasive surgical cases, the liposomal bupivacaine is injected along the pedicle screw tract prior to implementation of the pedicle screws. And this is done via a Jamshidi needle, and it's done immediately prior to screw placement. For open cases, you place the screws beforehand, and then you inject the anesthetic after you close the fascial layer, and you inject it circumferentially and into subfascially. This is our results. We had reduced hydromorphone consumption on post-op day 1. And overall, we had reduced diazepam consumption overall, reduced post-op day 1, and overall reduced narcotic consumption over the course of our observation period. We standardized the narcotic consumption based on morphine milligram equivalents, and over the course of their hospital stay, we had a 30% reduction from using a traditional field block to a TLIP block, which was 325 morphine milligram equivalents for the traditional block and 221 on average for the TLIP block. Our results show that TLIP blocks appear to be an effective adjunct to a multimodal analgesic regimen to reduce postoperative narcotics consumption following lumbar fusions, the two procedures that I mentioned, and it had no increase in the clinical risk. It was a 12% among the whole cohort. This is one of the largest studies to date analyzing TLIP blocks' effect on postoperative narcotics consumption. Although there is some problems with our study, as it is non-randomized, a relatively small sample size as well. And optimizing the application of intraoperative local anesthetics seems to be able to reduce a patient's postoperative opioid consumption, which can improve patient outcomes and reduce cost of surgical intervention by reducing their length of hospital stay. Although the reduction in the length of hospital stay didn't meet the level of statistical significance, the average hospital stay for TLIP blocks was 3 days, and the average hospital stay for traditional field blocks was 3.6 days with a p-value of 0.28. Yep.
Call up our next speaker, please. All right, also from the University of Miami, we'll be hearing from Dr. Victor Liu, predicting opioid use during hospitalization after lumbar fusion. Dr. Liu.
All right, thank you. Good afternoon, everyone. My name is Victor. I'm one of the residents down in Miami. I'm with Dave and Mike here, and thank you to Dr. Wang for letting us present. I'm going to be talking primarily from the same data set that Dave spoke about, but I want to put a little twist on it and make it more applicable to everyone, because it's very standard to think about how we can predict things. I want to challenge us all today to think about how we go about predicting these associations. We use a lot of statistics, but what does that actually mean in terms of coming up with conclusions that we can actually use in practice. So similarly to what Dave said, a common goal of what we do in our work, especially in the spine, is to reduce opioid use. It's been shown to have multiple benefits that I'm sure we're all aware of. So by creating this database and analyzing it through multiple different ways, multiple different techniques, I guess you can come up with multiple different conclusions. And the question for us in neurosurgery, the question for us in all surgery, in all medicine, is what do these techniques do, and what do they mean for us and their results. So similarly, this was a retrospective review. It was a single surgeon series conducted about a year ago. We abstracted all those basic characteristics down, demographics, consumption data. And then for this particular study, the difference was we used regression analyses. Now, for those that are familiar with these techniques, univariate regression analyses predicts an association, and then multivariate, then we can combine to predict independence and statistical significance. But pictorially, here's just the trend of exactly all the opioids that we have used in our series. You can see postoperative day 0 to postoperative day 7 for all these lumbar fusions. And you can see primarily it does peak around post-op day 1, day 2. But I'll bring up why that is a thing later on. effectively, when you boil it all down, you take the univariate analysis and you put them into this multivariate analysis, three things fall out: older age, male, gender. This has been previously shown by Dr. Yang, actually, in his ERES study up in Canada, to actually be predictive of lower opioid use during stay. And secondly, we also found TLIP block, which Dave also demonstrated through a direct comparison t-test study as well. So I guess when you take a look at it this way and this perspective, you can see that even multivariate regression goes on to predict these factors that we can then try to anticipate and maybe address. Interestingly, when you do a multivariate analysis, you get given coefficients, you get given gradients. So one of the first things you may see when you look at an analysis like this is numbers. Just to go back and show you where those numbers are, you can see under the multivariate column, you can see the coefficient. That's the slope. So if you remember back in maths, that was rise over run. So in this case, it's the number of MME units over the number of per day. And so when you translate this, sorry, per day, it's not per year. And so when you translate this, you can see that we can even begin to start to quantify exactly what these parameters do in terms of utilization of opioid. And then if you can start to quantify how things can be used, then you can start to quantify models as well. And that's where I think we're going to go with this. You know, we ultimately, all these stats are great, and this is for spine surgery, for all types of surgery, but what we're really going home with this is what use are these numbers? Why do we need them? Why don't we not just report a p-value if we have that? We have coefficients, we have slopes, so we need to start using them and have robust models for them to help benefit the patient as well as multiple other aspects of patient care. Ultimately, though, and this is where I want to challenge our series as well as all the other series that get presented today and moving forward, is that there are a number of limitations. First of all, single surgeon series, this obviously needs to be expanded, but moving forward from that, and I suspect with a lot of other surgical series in particular, length of stay, it's very difficult to actually compare statistically a patient that has stayed in hospital for 1 day versus a patient that has stayed in hospital for 5 days, and say that the patient that stayed in hospital for 5 days used more opioids. Makes sense because they stayed longer. And so what you have to start then thinking about is how does that varying length of stay start to impact your analyses? Because if you don't start to include this, it's going to confound your analyses, it's going to confound your conclusions, and it's not really going to be applicable to your patients as they present. And that's where we're going to go with next, the utility of opioid use by postoperative day, especially in the surgical setting. To say that something is more predictive on postoperative day 1 versus postoperative day 3 is not very useful if the surgery the patients rarely ever stay beyond postoperative day 3. And finally, confounding by operative indications. What do I mean by that? Spine surgery itself is probably the most susceptible to being driven clinically by pain indications. A patient presents with pain, they're more likely to be a candidate for surgery versus a patient that doesn't present with pain. And if someone presents with pain, and that is the surgical indication, we have to be very careful when we start to then say we operate and want to analyze the pain outcomes afterwards, as opposed to other things which are not operative. And finally, so what this goes to show is that we can predict associations by these types of analyses. Anticipatory pain interventions appear promising, and it's just a matter of being very careful, succinct, and concise with our statistical analyses to make sure that we can actually translate this to something that can be useful for everyone and applicable at a personal level. Thank you.
And finally, we'll hear from Dr. Anderson, who's going to tell us about patient-reported outcomes using mobile health technology in hepatopancreatic biliary surgery.
All right, thank you, and good afternoon, everyone. So I'm Meshka Anderson. I'm one of the general surgery residents. So essentially, I'll be discussing using e-platforms to collect real-time patient-reported outcomes in our hepatobiliary surgery patients. So these patient-reported outcomes are becoming increasingly recognized as essential to patient-centeredness and patient-centered care. So some of the outcomes that we typically measure include length of stay, post-operative complications, and readmissions. And these measures typically limit patient-centeredness and limit patient engagements. So these mobile e-platforms, especially apps, are improving patient compliance and their engagement, especially in the post-operative pathways. They also assist us provide procedure-specific and disease-specific education to our patients. So the aim of this particular review is to look at outcomes of implementing these e-pathway or e-pathway mobile applications in terms of collecting real-time data from our patients in the setting of ERAS program. And we utilized a proprietary app created by Seamless MD. So we collected data from March 2018 to April 2021 with patient-reported outcomes of pain, opioid use, nausea at our HPB center. Patients had to be 18 years or older, and they had to be scheduled for an elective procedure within our hospital. If they were still within 30 days post-op, those patients were excluded from the analysis. For us, our interest at this time was patient satisfaction and patient engagement with these apps in their care. We integrated 2 surveys to assess quality of life of our patients. Our total enrollment numbers were 422 individuals, of which about 90% of them activated their accounts to participate. Of those that activated their accounts, about 60% remained engaged in the app during their hospital stay, and another 51% remained engaged post-discharge. Out of the total questions that assessed quality of life, about 41% of those questions were completed by our patients. And our quality of life survey was completed at a rate of about 38%, 30 days post-discharge, and about 26% at 90 days. Looking at patient satisfaction, we looked and we saw that there was a very high satisfaction rate. So close to 90% of our patients said they would recommend these apps for any patient undergoing a surgical operation. They stated that it made them feel more confident and prepared before surgery in terms of the educational tools provided. And about 65 to 75% of those patients said the app made them feel less worried before surgery, more confident at home if they had concerns, and made them feel less worried while at home. So looking at this specific app that we used, we provided service-specific perioperative guidance to our patients that tracked education, symptoms, and daily recovery steps. It also allowed us to provide real-time gathering of in-hospital symptoms or post-discharge recovery outcomes without using additional resources, such as phone calls to check in. And it also allowed us to integrate almost a triage system where if patients were having a certain amount of symptoms, it could direct them to, okay, call the office, or you need to visit the emergency department. And when we look at the overall goals of ERAS, that's extending beyond just collecting clinical data, but more focusing on patient social well-being, economic well-being. These new apps allowing patients to self-report are allowing us to collect a lot more data in these new parameters. So eHealth platforms have been assessed during multiple papers, especially in different subspecialties. So in this particular paper, these patients were undergoing elective cardiac surgery, and they collected data while the patients were inpatient. This allowed them to predict length of stay and potentially discharge dispositions, such as these patients might need to go home, or these patients may need rehab depending on their level of reported pain and ability to ambulate. So we are seeing benefits from both a clinical standpoint and from a patient satisfaction standpoint with using these platforms. And then for us, this was to get a sense of the patient's engagement. We initially assessed data from a 10-month period and then over an additional 36-month period, and we saw that patient engagement stayed about the same. So in conclusion, we did see a decreased long-term participation in these surveys, but of those that participated, we saw a very high satisfaction rate from both clinicians and both our patients. We were able to provide education, symptom tracking, real-time compliance, and patient engagement. And we saw that this was more sustainable and resource efficient than typical phone surveys and office visit that would typically allow you to collect data in a delayed fashion versus real time. Thank you.
Thank you very much. Do we have any questions for this group of speakers? Awesome.
I'm not this tall. Hi, this is for the second presentation. So you have these predictive models that you've created. Do you have any plan for actually utilizing them, developing them into a tool? And kind of second follow-up question, what are your thoughts on modifiable patient factors and incorporating those into predictive modeling? Thank you.
Thanks for that question. Look, I can't say that we have exact predictive models. That's going to require a lot more, perhaps machine learning and everything. What our data shows, like through these models, is what the difference is. So, for example, if you're older, then by each year of age, you may be expected to use, say, for example, 10 less MME units of opioid compared to someone that's 1 year older or younger than you. But the question then becomes, what's the goal? You know, like, what's the threshold? Does every patient have like an ideal MME unit that they should be using during their stay? Who comes up with that? Who defines that? That becomes very individualized. I don't know if there's an answer for that just yet. But I guess there is a point to where it can become toxic, a threshold which is above what we would expect anyway. In answer to your second question, how could we use these as models? Well, you identify these parameters, things like, for example, gender can't be changed. But then you can, if you can identify more parameters, you can create sort of a multivariate, equation of some sort. But again, you have to ask yourself, if I can predict how much opioid a patient is going to need, how does that help me as a practitioner? Just because you can predict how much they're going to need, clinically, how is that going to help you do things? Apart from perhaps have the hospital ready for all the medications, for me, I think the challenge is how do we translate this to transitioning away from opioid medication. And maybe that is it. Maybe you have to understand how much opioid a patient would be expected to need, and then you can start to guess at what else I can use non-opioid equivalents and have that in stock to transition away from it.
If I can tie it into Dr. Ivan's presentation previously, I think he was showing us that perhaps we might be overshooting on some patients. And so maybe that's where having more of an adaptive you have a prediction of how much they're going to need, then you adapt the protocol accordingly. Our strategy right now is to give everybody the most that we can to minimize the opioids, but not everybody might need that. So we don't often think about the toxicity of our non-opioid medications as much as perhaps we should. Greg.
Hi, just a question for Dr. Anderson. Did you get a sense of, I know it's hard to answer this question, but of patients that stopped using the platform, any idea why they would have stopped using it? Because I think the whole idea is to try to find something that many patients will be able to use, that'll be user-friendly. Because in a sense, if you get to a point where 50% of patients are using it and 50% are not, then you actually are going to be using two different ways of assessing those patients. So just your thoughts on that.
Yeah, so I think, when you looked at the initial activation, it was at 90% initially. And at some point you get to where there's about, the immediate post-operative period where a patient may not, be up to going into an app and filling in that information. We actually tried to mitigate that by, allowing potential family members to engage with or other trusted loved ones who are in the room with those patients to assist with giving that feedback also. And a lot of times, especially when you get to the post-discharge period, it turned out that a lot of those patients didn't necessarily feel the need, the feedback that we got to fill out those questionnaires just based on how their recovery was going.
To follow that up, so Seamless MD is like my baby. So we call the patients like throughout their post-operative course. So once they're discharged from the hospital, they will fill out the questionnaires, and if anything flags yellow, which means it's like a moderate risk of them having a complication or having an infection, like if they, for instance, report that they had a fever of 101.2, then it will flag yellow, and I call them that day and talk to them about, what medications are you on, what have you taken, how are you feeling otherwise, pain, like all those types of follow-up questions. And so we know that with the 90-day mark, the patients are not continuing to fill out surveys because they feel better. So people that are recovered and feel like that they're doing better, like oftentimes they're back to work. Some of our other patients are starting their chemotherapy after surgery, all of those things. They've got a lot going on that is outside of their recovery from surgery in the acute phase, and so they're no longer filling out surveys because they no longer feel bad. We had the most success inpatient in the initial postoperative period, and then about 1 week once they got home. So about 1 week after discharge, we had the most success with people filling them out consistently, and their families helping to do that because they weren't feeling great.
Thank you.
Okay, thank you very much.
Thank you, sir.
we can move on to the next session. Let's see. No, Greg's coming too. It's not just you. All right, our next speaker is going to be Dr. Greg Nelson, who's going to be presenting this on behalf of Dr. Parrish, who unfortunately was not able to make it down, and the rest of our group. So Greg's going to be talking about the effect of pharmacotherapeutic prophylaxis on postoperative complications, length of stay, and readmission within an ERAS program, a retrospective cohort feasibility study. Greg, go ahead.
Great, thanks, Kevin. Thanks, everybody. Really my pleasure to present here today on behalf of our team. As Kevin said, unfortunately, Richard was not able to make it. So these are my disclosures, none of which are relevant. I am the Secretary of the ERAS Society, which basically just means I'm very passionate about this subject. So I think ERAS is about breaking down barriers, allowing people to work outside of their silos, and this was a brainchild of Richard Parrish, who's a PhD clinical pharmacist who was at Mercer. He actually used to work with us at Alberta Health Services and then moved down south. But he kind of came up with this idea that surgeons, anesthesiologists should actually be working more closely with clinical pharmacists. I think many of us do this, but maybe not to the extent that we should. So this was an initial publication from our group that really, proposed a little bit closer collaborative work between surgeons and clinical pharmacists, and the whole idea to try to, generate applied research questions for comparative pharmacotherapy analyses. So this is really a bit of a feasibility exploratory study, a bit of a work in progress that we're going to present to you today. And really, as I said, the contribution of pharmacotherapy prophylaxis, these are some of the things that are embedded within ERAS protocols. Many of us actually take them for granted because we think that they're being performed as they should. And I think sometimes when ERAS teams are reviewing their compliance, they may not necessarily be focusing on these areas as much as they are others. So basically, we wanted to examine protocolized care within ERAS pathways related to surgical site infection, VTE, and postoperative nausea and vomiting, recognizing that these are quite common reasons for delay of discharge. So the objectives were to characterize pharmacotherapy and identify relationships between prophylaxis and SSI, VTE, and PONV. And we also had secondary outcomes that we were looking at, try to determine if there were any relationships between prophylaxis on length of stay and readmission. The methods essentially was a retrospective cohort study of 250 patients from my hospital in Calgary, Alberta, Foothills Medical Center, which is an ERAS site, in basically colorectal and gynecologic oncology surgery. And all of these patients' information was extracted from the ERAS interactive audit system. And as you can see here, we looked at patient characteristics, operative characteristics, postoperative outcomes, obviously all the pharmacotherapy prophylaxis details, and we'll tell you what we found. So we thought that we needed to have about 250 patients, essentially to be able to start to see some effect. And I love it when people say this is a busy slide, but this is a busy slide, but really the take-home message here is that the cohorts were relatively well matched. You can see here in terms of demographics and comorbidities, about 60% of the cohort in both surgical types had malignant diagnosis. We chose to look exclusively at our open gynecologic oncology procedures, so both staging and debulking. And then the colorectal cases you can see here are both laparoscopic and open. So just in terms of SSI, the most common IV antibiotic prophylaxis was Ancef Flagyl, which 75% of those received within 30 minutes of incision. That's pretty typical for most centers. Mechanical bowel prep was not given in any of the gyne-oncology cases. For the colorectal, none was given in 40%, oral antibiotics only in 20%. There didn't appear to be an association with SSI, length of stay, or any of the readmission. You can see that very low SSI in both groups. For the VTE, again, most frequent regimen used for both groups, compression stockings, unfractionated heparin, typically after induction. Weight-based adjustments were used in just about 10% of cases, and again, very low occurrence rates of VTE, which we would expect. For PONV, this is where the most interesting signals were starting to come. Obviously, PONV was related to longer length of stay. Many patients received more than 7 antiemetic doses. Interestingly, aprepitant use was associated with a lower length of stay in gyne-onc, but not the colorectal cases. And one of the take-home messages that we found was that there was a great deal of variability in terms of PONV prophylaxis. We also found, not surprisingly, that more MME was associated with longer length of stay and also PONV. And then just some final outcome variables. I think, again, if we look at the differences in length of stay of patients who have PONV versus those that do not, clearly we need to be doing better in these areas. So really, it's the first study in the literature to characterize pharmacotherapy prophylaxis in ERAS protocols. Obviously, this is just still a work in progress. Our limitations include it's a single center. It was done during COVID. Obviously, we intend to perform a multivariate analysis looking at covariates. And I think, when we look at SSI and VTE, the guidelines appear to be followed, and this appeared to be associated with low complications, length of stay, and readmission rates. But clearly, our teams need to do better in terms of PONV. And so we hope to be including more sites. I know Dr. Elias, his team from Harvard, will be contributing. And this is also an open plea to everyone in the room. If anybody wants to contribute to our study, you can email either Richard or me. Thank you very much.
Now calling on Misty Yeller, who's going to tell us about the COVID-19 pandemic and ERAS, how nursing staffing shortage affects compliance.
Hi, everybody. So I'm one of the nurse practitioners with HPB Surgery, and I'm presenting on behalf of Mary Neal Irvine, who is on maternity leave and was unable to come and present her research. So basically what was happening is that when we started our ERAS unit with HPB specific, we thought that a 1-to-4 nurse ratio was perfect to be able to increase mobility, increase compliance with mobility and documentation, and all of the nurse affected components with each one. And so whenever COVID hit, the nursing shortage happened, and then we got reallocation of our staff, and everybody knows exactly what happened. And so when all that happened, we realized that our compliance rates were low across the board, but mainly in mobility. And we were seeing nurses walking patients, we were seeing the techs walking patients, but no one was documenting anything. And so we started investigating that. So Mary Neal wanted to take a turn to where she just kind of did an observational research that just kind of showed what we actually found when it comes to nurse-patient ratios. So our mobility compliance dramatically dropped during the pandemic, and we had increased nurse turnover in our ERAS recovery unit, and we suspected that that was part of the cause, is that they just literally did not have the time to do the documentation as they had previously done. The aim of this was to evaluate whether or not there was an association between the diminished compliance with mobility and that of the staff shortage, and then we utilized it in our primary ERAS patient population with HPB, which is our hepatectomies, our distal pancreatectomies, and Whipples, and we looked at pre- and post-COVID error, and then we looked at the nurse-patient ratios. So the expectation since 2016 has been that the nurses are going to document mobility every 2 hours. We document in time instead of distance, which was a huge undertaking. It took us about 18 months just to get that one little snippet to happen, and it still doesn't always happen. And that was for compliance tracking purposes and EIS database. And so this is done from our EMR, and we do weekly compliance tracking on about 10 elements, and then we do monthly on about 30 elements that we look at as a team. And so when we're weekly looking at this, we can see change pretty quickly, and hopefully we can affect change pretty quickly. So we took data from the chart and we entered it into just a spreadsheet, and that we looked for the time frames. And our threshold was set at 70% as a minimum standard, and the staff averages were obtained and recorded. So the results were from March of 2019 to February. Our pre-COVID, we were 5 out of 12 months we achieved the 70% documentation goal. Nurse compliance average was about 60%, and the nurse-patient ratio then was 1-to-4 about 80% of the time. We had some nurse turnover prior to COVID as well, and so we were experiencing some of that left over, I think, when COVID started as well. Then our post-COVID, we did from March of 2020 to February of 2021, and it was 2 out of the 12 months achieved 70% with a total compliance of only 48%, and our ratio was 1 to 6 100% of the time, and at times we were 1 to 7, especially on night shift, with the charge nurse taking 7 patients. So it was dramatically different than what it had previously been. So this is just kind of a graph where you can see where we went month by month, and we literally just looked at the compliance rate and then what our minimum standard was. And you can see how that looked pre-COVID. It's kind of up and down, and we had some ugly months right around November and December of that year. And then you look and see what consistently you had a decline. We had one good month in November, and I think that's when all of us were kind of losing it over the whole thing. We had one really good month, and then you can see where it consistently declined the whole time. So in conclusion, I would say that in the era of COVID pandemic, the overall compliance significantly diminished. I think that there is a relationship between overall compliance with the components that are nurse-driven and that are specifically related to nursing and the techs and everything on the floor. I think that we can say that there's definitely a relationship. I don't know that it's necessarily cause and effect. We're looking at that now as far as going forward. So now that we have nurse-patient ratios that are back to normal at 1 to 4 the majority of the time, it's about 70% of the time now, and we're training staff again, we're gonna look and see what that looks like to see if we can correlate again that we have better compliance with better nurse-staff ratios. So that was essentially it. We think there's a correlation.
Okay, our next talk will be from Leslie Coots, who's going to be telling us about enhanced recovery after surgery, impacts and outcomes in an implant-based breast reconstruction population.
Hi, I'm Leslie Coots. I'm a nurse practitioner with the Division of Plastic and Reconstructive Surgery at VCU Health. I'm here today to present enhanced recovery after surgery, impact and outcomes in an implant-based breast reconstruction population. I have no conflicts of interest to disclose. Breast cancer is the most common form of cancer for women in the United States. In fact, 1 in 8 women will develop breast cancer in their lifetime. From 2000 to 2017, breast reconstruction rates rose 35% across the United States. Breast reconstruction, even though essential to restore the shape and look of a native breast, comes at a painful price to the patient. It has been long known that women who undergo breast reconstruction have a significantly higher incidence of pain after surgery compared to women who undergo mastectomy alone. Research shows that multimodal analgesia and enhanced recovery after surgery protocols have led to improved outcomes in implant-based and autologous breast reconstruction. This quality improvement initiative examined how an institutional ERAS protocol with a multimodal pain management regimen compared to our previous postoperative care and pain regimen within a 22-month period. 2 groups of 100 patients each were compared, pre-implementation and post-implementation, with a t-test for statistical significance. We examined patient demographics, length of stay, average pain score, total inpatient morphine milligram equivalent, or MME use, discharge prescription MMEs, and the number of discharge muscle relaxant prescriptions. Here are the pre-implementation and post-implementation patient management protocols. Interventions changed are highlighted in red. This QI initiative was designed with protocolized de-escalation in mind. The protocol implemented multimodal pain medications, which for us were Tylenol, gabapentin, and ibuprofen, to all patients undergoing implant-based breast reconstruction and removing the Foley at the completion of the operative case. The protocol also loosened the MPO restrictions preoperatively to ensure adequate nutrition prior to surgery, among other elements listed in this table. We saw statistically significant reductions in average length of stay, average pain score, total and daily inpatient average MME, discharge prescription MMEs, and the number of muscle relaxant prescriptions provided. Our experience highlights that ERAS protocols, when comprehensively implemented, affect positive change within the implant-based breast reconstruction population. There are several opportunities for obtaining additional information with this project, including surveying the patients on their postoperative opioid use after discharge, since our current data only accounts for the opioid prescriptions provided. This survey data could allow us to further reduce our overall prescription rates of opioids to prevent misuse, abuse, diversion, and addiction. Additionally, we could survey patients on their experience and satisfaction related to the ERAS pathway. Next steps for our breast reconstruction ERAS pathway at VCU Health include implementation of the intraoperative portion of our institutional ERAS protocol and more coordinated efforts in both our pre-anesthesia clinic and at the plastic surgery preoperative visit. VCU Health is building additional infrastructure within our preoperative anesthesia counseling clinic to support prehabilitation, hemoglobin A1C optimization, and anemia management prior to surgery. The PACE clinic will also provide chlorhexidine bath cloths and carb-loading drinks to be consumed 2 hours prior to surgery. We plan to train our clinic nursing staff to provide preoperative education on the ERAS bundle to patients so they can be informed and better prepared to actively participate in their care during hospitalization. Information and expectations about the surgical experience can be provided at this visit. We anticipate ongoing improvement in outcomes and patient experience with continued implementation of the ERAS care pathway for breast reconstruction patients. We will continue our data collection and monitoring to ensure continued overall uptake of our practice change over time. Thank you for allowing me to present today. Here are my references. And if anyone has any questions, feel free to contact me or my team members at these email addresses.
Thank you for those great talks. Do we have some questions for this group of speakers? Dr. Verhedes?
Thank you, Dr. Nelson. Craig, it's great actually to see you here.
Nice to see you in person.
Yes, finally. I enjoyed your talk. As usual, as always, you're innovative in the way you think and the way you conduct research. I have a very, very specific question of how you documented and you captured the data that you presented. All of them, they are electronically done the time that the medications are administered, or there is retrospective population of the data points?
Yeah, great question. So as per kind of what happens at our medical center, when the nurses are inputting data into the ERAS interactive audit system, it's a combination of, reviewing live charts on the ward. We have also a electronic chart live while the patient is an inpatient. And then that's primarily where we had additional information through the MAR, so medical administration record, and then also the anesthesia manager. So again, that's where all of the intraoperative medications would have been recorded. So
have you done an analysis to see what is the percentage of error entries? Because that would be very important, especially with patients with low observation of outcomes like DVT. We need to know how many of this data is wrong.
Yeah, so interestingly, so both Swiss and Swedish hospitals have recently undergone ERAS validation studies. We are hoping to participate in that as part of this particular study to see. I can't give you that actual answer, but you're absolutely right. We should be looking at that. But yeah, that's a good question.
And the last thing is your request for participants in the study. Does it extend beyond OB and GYN? Can you get HPBs?
Absolutely, yes. We want to get some real surgery in there, absolutely.
You know how to talk to an HPB surgeon.
Greg, you volunteered our group very readily there. I don't know. All right. All right, next question.
So I'm a colorectal surgeon, so not a real surgeon, but still I would ask you a question, Dr. Nelson.
Sure, yeah. Well, imagine what I am as a gynecologist, right?
Yeah. No comments, no comments.
Trying to keep it lively.
Yeah, no, I know. I'm not offended.
Okay, let's do it.
Yeah. So I commend you for your very low SSI rate.
Yes.
And you attributed that to your compliance with the protocols. However, the bowel prep is all over the place in your study. And so what is the protocol for bowel prep at your hospital? With 37%, it's hard to understand. And before, I have a question for Misty, I believe. You were one step away from giving us some great information, right? You proved, you showed us that you have a decrease in staffing, decrease in mobility, decrease in compliance. What about outcomes? You were right there, and I'm sure you have that data to show us. We did a study at our institution. Dr. Stringfield is the first author, and we were able to correlate that more or less, because those were very difficult times for everybody. Not only we were down in staffing, we were down in the ERAS coordinator. So we were lost all over the place. So Dr. Nelson first, and then
Sure.
Misty, thank you.
Yeah, so in our gynecologic oncology cohort, as you saw, we had 0 mechanical bowel prep period, and we've done that for many, many years. In this particular cohort, which is a combination of staging and debulking, overall there was a 20% bowel resection rate in the gyne-onc cohort, just simply because it was a combination of staging and debulking. Our colorectal group, like others internationally, are all over the map in terms of their bowel prep protocol, because they have also been influenced by the back and forth between, Cochrane evidence around mechanical, but everybody's now trying to figure out what do we do in terms of introducing oral antibiotic prep. Is it mechanical, oral, or both? So I think that really, this time period of collection reflects that some of those surgeons were doing both, some are only doing oral antibiotic prep. So, my hope is if we were able to get more people on board, is we might be able to help answer that question a little bit better. But that's an excellent question, yeah.
As for mine, thank you very much. It was a good question, or comment, but I would think that's the next part of it. So when we actually show, because we think there's a correlation between the nurse-patient ratio, so we used a 1-to-4 ratio before, saying that if a single nurse only has 4 HPV patients, then he or she is going to have better ability to do the correct documentation and to do the mobility and all the components that we need them to do. And so for us, readmission, length of stay data, and major complication data is something that we track on every single one of our patients anyway, so it'd be fairly easy for us to get that. So I think after we change our ratios back to 1-to-4 consistently, and then that we're back to where we're normal, and we look at that and we see if there was a correlation that actually improved compliance, then we'll look at our complications and we'll look at our outcomes.
Alex, I think we have to finish up questions.
Sounds good.
Yeah. All right, Dionysus wants to pop in here for a quick comment. Go ahead.
Oh, yeah, go for it.
All right.
It's on that question, that's why it's very, very quick. So it depends, I don't know, where was it? Yeah. It depends on which component of the outcomes you look, because we have the ability to monitor our outcomes in real time. So I can tell you that the clinical outcomes did not suffer. In fact, if you go to the financial outcomes, they improved because we are using less nurses. Where we really plummeted was patient-reported outcomes. Patients hate that. So if you just focus on the clinical outcomes, you are not going to get the true outcome of what has happened with reducing the nurses. You need to see all 3 facets. Now, I suspect that if you continue the 1 to 6, this is not a sustainable model. You will start losing all your experienced APPs and all your nurses. So it's not only I focus in the clinical outcomes and I'm done. Still, we get the job done. The question is, how long can you sustain that?
Great comment. Alex?
Yeah, great comment and great presentations. This is for the second presentation. It's just fascinating opportunity for research looking at kind of the stress test that COVID put us through, but also ERAS programs in general, and seeing what is resilient and what makes a resilient program and what stays and what probably needs to be improved and changed and modified. So are there any thoughts in like how your program's going to change to make maybe nursing workload a little bit more easy or easy to adapt with new different teammates and that kind of thing? Thanks.
Don't you worry, compliance is super important. So I make changes on a daily basis. Dr. B can tell you. So we are very active. Like I said, we do weekly. So we have an ERAS nurse who was actually taken away from us during the COVID for about an 18-month period of time, where they had so many other things that they honestly weren't doing a whole lot with our compliance data and stuff that we normally do. So we're back to doing weekly meetings on our compliance. We're back to doing monthly meetings on our compliance. So weekly, we look at about 7 things, and then on a monthly basis, we look at about 30 components. Things that we can change, we do, and we typically do it in real time from like a week-to-week, day-to-day thing. So Keith will come to me and he'll tell me like, hey, 3 people didn't walk this morning, or 3 people weren't out of bed on time, or if I round and people are not out of bed, then I can assure you there is active participation amongst our staff to get people out of bed immediately for the time period. So I would say that we're very active with making sure that those components are done, but it honestly has been a huge stress test, and I think that we've all seen that across the board in a lot of different aspects. But we just try to change the things we can when we can.
Yeah, we need institutional enhanced recovery. So how do the institutions recover from the stress that they have been under? So that be meta ERS. Thank you very much. I think that ends this session.